So I'm Thomas, as I said. I'm both a clinical urologist in Paris, and I'm also teaching anatomy in Paris Sud University. There is a wide range of hypotheses whether the urethral stump length, its angulation, the supporting structures, the coordination, and of course, if the nerve supply may change the recovery of postoperative continence. Reeves demonstrated that the postoperative recovery, continence recovery, was quite well correlated to the nerve-sparing technique.
I will present our experience with extraperitoneal robotic-assisted radical prostatectomy. You have a balloon dilator that you use to create the space. And that's essentially what we have with respect to a scope that is placed within the balloon, so you can create the space under direct vision.
The only prospective study was written by Steinek. It's a multicentric study over 3,000 patients. And if you closely have a look at the urethral sphincter, there is only one nerve that is reaching this sphincter, the pudendal nerve.
Now on the left side, the space being created using the smooth trocar. This is a robotic trocar being inserted in the left lower abdomen.
This is one of Dr. Tewari's drawing, and he welcomed me 2 years ago with this drawing, and he said, "Thomas, let's work on this together. Let's find some evidence to see if it's real or not." And this was our conception of the male urethral nerve pathway. This is the level of evidence that we could summarize.
In conclusion, it's an efficient approach. It avoids the abdominal cavity just like we used to in open radical prostatectomy.
My conclusions: several nerval pathways reach the urethra. There is evidence for autonomic innervation, and there is an anatomical rationale for NVB preservation that could improve the continence recovery. However, it's a complex neuroanatomy, and I think it deserves further anatomical studies to address this complex anatomy.